Not yet. Great. This is the Monday, May 4th, 2015 Edina Community Health Commission meeting. I'm going to call the meeting to order. The first thing we'll do is approval of the meeting agenda. Are there any changes or additions people would like to make to the agenda? If not, I'll take a motion to approve.
Move approval.
Any second?
Second.
All in favor?
Aye.
Okay. And then we will look at the April meeting minutes. Any changes or additions? That folks.
Move approval.
Any second?
Second.
All in favor?
Aye.
Okay. Community comment portion of the meeting. Seeing no community members, we'll close the community comment portion. And we'll move into our reports and recommendations section. And the first thing we will have is a mental health substance abuse subgroup discussion. And Joel, I'll turn that over to you.
Thank you, Allison. We got organized last month because we had a short period of time to prepare for the presentation that's going to follow. We communicated by email and kind of set up a structure for how we're going to approach our topics for the year. And I thought I'd share with the group just briefly how we plan to do that. It might be helpful or interesting to you. We've agreed to report out once a quarter, more of a full report. And to get prepared for that, we thought that a month or two before we report, we'd start talking about a topic. We might get together to meet, or depending on schedules, we might do a lot of the work by email. The other thing, I guess, that we did was talked about what happens after the initial report, and most of these basically are opening the topic up. And the idea is that if you have a number of topics and you start them all at the same time, then you're likely not to accomplish much. So we're starting them in a staggered basis, and then basically we'll be at different points and kind of working on different projects. Much of the work might be done by the first meeting, but any follow-up would continue in the following months. And then, we'd give, reports on what's going on. And at the end of the year, we'd give a summary of kind of things that are done, things that need more work, and maybe, if things don't work out, if we've dropped any initiatives during the year. And also to make sure that we kind of divide up the work between people. For each of the 3-month presentations, we had assigned 2 people to work on it and kind of vary it in terms of who leads and throughout the year. So not one person is the work is divided up. And the way we've done that, the way I set it out, and of course this can change depending on schedules, is Matt and I handled the first report on binge drinking with all age groups. For the August meeting, when we be up again, the topics youth prevention, early intervention. And these topics came off of the work plan. So I went through and pulled the things that kind of had our name on them in terms of responsibility. Matt and Megan are assigned to work on that. With our students, of course, we don't know, year to year that they'll be around. So if Meg is not with us at that point, then we'd find somebody else, perhaps a student, to work on it. In November, Britta, who will be back from her leave and be actually in charge of our group at that point, and I will be working on the issue of access to care and parity. Parity is basically the idea that behavioral services traditionally have not received the attention that other services have. In February of next year, the topic would be public attitudes, stigma, and denial. It's basically the things that are preventing people from getting services. And Matt and I are working on that one again, according to the schedule. And finally, the last thing, which actually occurs 12 months from now, would be stress management problems and approaches, Britta plus one other person. So we're hoping to, by doing it systematically, that we'll be able to get more work done, divided up, and see better outcomes.
Great, thank you. And just for our new members, Steve, just so you are aware, we have divided the group into 3 subgroups like he just mentioned, and so you will be taking Mike's spot on the adult health groups. So Ginny and I will clue you in, because we are also in that group, so we will clue you in when we get to that point.
Sounds good.
So the next part of the agenda, we're just going to look at the work plan. We have our next meeting in June is actually our work session with the City Council, and we have that is the meeting where we present our work plan to the City Council and have a discussion with them. And so at our last meeting in April, we started looking at the work plan again and talking about revising it to fit the new plan that Joel just outlined for the group. And so Jeff, our staff liaison, and I met this month and kind of went through the original 2015 work plan that we had and kind of reformatted it based on the groups that we restructured by. So what you have in front of you, you should have a copy of the original 2015 work plan, and then you should have one with a revision date of 6/2/2015, which is what we will present to the City Council next month at our work session. And so at this point, we just wanted to walk through it real quick and get people's feedback and thoughts. It is very similar, but it's just formatted a little bit differently, and some of the language was changed just to encompass a little bit more of the work we're planning to do. So you can see the first initiative, really work with the Edina Resource Center and Bloomington Public Health to promote the health of the city by focusing on our 3 key areas: mental health and substance abuse, child and adolescent health, and adult physical health. And we kind of took the main points from the original work plan and slotted them into the categories. Does anyone have any thoughts or changes they would like made to this first page, the way we divided these items into subgroups? Okay. So then the second page is actually quite similar to the original. Again, we're talking about kind of the content on the community health page on on the city website, as well as some of the other resources that are available, media outlets and whatnot. We did specifically talk in the second page here about coordinating with the school district about the creation of the Student Wellness Chemical Health Coordinator position, which is what Jeff had reported to us at the last meeting, that was the direction that the school district was going. And so we changed this one slightly to talk more about, to specifically name that person, because that's the direction that the district is going, and really put that into our work plan so that we do have kind of a concrete role in that process. I think the lower 2 are pretty much the same. We did specifically want to talk about and list out the SHAPE survey in the data collection one at the bottom, just because that is the new data collection that the county is using, and we wanted to specifically list it here. Ideally with a thought for the future, we have learned that some cities have been able to purchase access to better data for their city. Thank you. So we wanted to list it here just so that we keep talking about the SHAPE survey, so that in the future when Edina has the option to, again, hopefully when they do the survey again in a few years, has the option to really gain better access to our own data.
Allison,
Yeah.
do you know when the actual data will be available for our area?
I believe they're literally just wrapping up data collection right now, so I think I heard 6 months is when they will start to roll it out. But again, we're going to be looped in with cities like Richfield and Eden Prairie, and it'll be hard to know exactly which data is for our city. But we were notified after the fact that Bloomington purchased rights to get more data for their city specifically. So we will look at that and keep this probably on our work plan, just so that when we get to probably 2018 is the next time they'll do this, hopefully the city council can budget a little bit and we can have discussions leading up until that point so we can get some good data specifically for our citizens. And then the last, the new initiative that is on the new revised work plan that was not on the old one is related to medical cannabis. As you remember from a couple months ago, we did have a discussion with Bill Neuendorf and this has come before the city council, and so we just put it on here in terms of possibly anticipating a request from the city council coming related to medical cannabis if they get a request, so. Any thoughts related to the revision of the work plan?
With the medical cannabis, the substance itself falls within the area of mental health, substance abuse potentially, but the treatments are directed toward physical health.
Yep.
So how that is approached, I think we just need to figure that out.
And I think the city still considers it a zoning issue purely similar to pharmacies and things like that. So yes, we will wait to hear from the city council as to whether or not they want input from us, but we'll leave it on here for now. We may discuss it at next month. Any other thoughts, changes you'd like to make to this? Okay, then I think we will just go ahead and present this to the city council the way it's written right now, and then at our June meeting, and hear what they have to say. So our next item on the agenda is going to be members of our mental health substance abuse subgroup are going to present on their binge drinking focused discussion. And Joel is going to present this as well.
Thanks. Matt and I have been working on this for the last month or so, since the last meeting. And earlier in the year, we had prepared a lot of data. So this covers that, plus a lot of additional work that we've done. And you'll find a fairly complete report, I think. One thing, I'd like to go all the way through it because some of the things are related, and hold questions and comments until the end, if that's okay with everyone. Mm-hmm. Just write them down, and I'll try to answer them, or perhaps Matt can also if he wants. Basically, I'm going to talk about one of the top priorities for this year, which we identified earlier this year as being binge drinking. And it's binge drinking not just for teens, but for all age groups. So we, in the past, we looked more at the teen binge drinking issue. Now we're looking at all populations. Okay. And the slides will be in front of you. Probably you don't have to look at me. You can look at them. First point, most of us are impacted by substance abuse, know people who are impacted by substance abuse or have been impacted ourselves. When I worked at Hazelden, we did a national study looking at people's experience with addiction. At that point, we found that 1 in 3 families had a member of the immediate family that had a problem with substance abuse. 1 in 3 people. But if you expand it to the expanded family with other household members, it was more like 80%. So that's a pretty huge number, and as you'll see, a lot of the families had multiple people with issues. So they talk about addiction running in families. Well, that's one example of it. So that also carries over to friends, neighbors, coworkers, and everybody else. So it's in the newspapers and it's around us. There's a range of drinking behavior I'd like to kind of lay out. Approximately 2/3 of Americans, adults, drink at one time or another. It's higher for people with more education and income. And more than half of those people have had a drink in the last 30. So it's not like 5 years ago they had a drink, but it's pretty current. Non-drinkers are about 1/3 of the population. That includes people that have had a drinking problem but are in recovery. Moderate drinking is 2 drinks for a man, 1 for a woman. However, we find that 20% of the population of drinkers is consuming 80% of the alcohol, which suggests that some of the a lot of the drinking is not very moderate, and those people tend to be the people that develop addiction issues. Alcohol use definition in the U.S. has two different definitions. They're slightly different. You can read them, but essentially, one is focused on lifetime use, and it basically differentiates between the amount of number of drinks that a man versus a woman need to drink. And the other one is more focused on current use. I guess I'm ahead of myself in the slides, so I'll hold that for a second. Severe drinking, there's binge drinking, but there's also heavy drinking, which is basically binge drinking multiple times in a month's period. 5% of the population drank heavily, and 17% binge drink. So like 1 in 3 people that binge drink have more severe problems. 17 million people in 2012 over the age of 18 binge drink. That's twice as common with men with women and also among professionals. Adolescents, it's almost 1 million between ages 12 and 17. And those that start early are much more likely to develop addiction problems as adults. Here are the definitions that I started talking to. You can see the first one connects to blood alcohol level of 0.08, which is the standard for DUI. And it's thought of as 5 drinks for a man and 4 for a woman. And it doesn't talk about the last 30 days, it talks about at any point. The second one, 5 drinks, either sex, 1 day at least in the last 30. So they measure slightly different things. So if you're talking, you have to be a little careful about which definition you're using. The other thing I would note is that 80% of other countries have a standard for intoxication of below 0.08. The most common level is 0.05, and I'll explain later why that's true. But there are a couple complications. The first one is that the standard drink size is only 1.5 tablespoons, a small amount. So the drink that you're having is mostly not alcohol, and it's very hard to detect how much alcohol there is in a drink. And often the serving sizes are more than one standard drink. So if you ask people how many drinks they've had, they don't actually have the ability to often to say because they don't really know, which is it makes it kind of a dangerous situation. Second, drinking varies, the impact of it varies by gender and weight. So for example, if you look at this little chart, it's very small, I admit, but if you're talking about a very light woman who's had 1 drink, if she has 2 drinks, she's up to 0.08. But if you go up and double the weight, then essentially you can double the number of drinks before you reach that level. And women, actually, the research suggests, process alcohol a little differently, and that also contributes to the issue. It's important also to note the impact of this has on age. Imagine your typical teenager. They're significantly lighter than their parents. They're thin. They don't have as much body weight. So that a drink that they have is going to have more impact on them, regardless of other factors, than would have on someone that's bigger. So what happens when you drink? Well, information I found suggests that up to 0.03, it's hard to observe any effects. From 0.3 to 0.6, if you look at the effects, they're mostly kind of making you feel good, positive symptoms. But if you get above that in the 0.5 to the 0.10 range, you start to have more troubling symptoms. So when you're in that area, that's when you start to have problems. And if you look farther on the chart, you'll see that once you get up to 0.20 or 0.30, then things get very troublesome. And if people are lighter and they are having bigger than average strengths, they may be in a place where they really don't expect that they're going. I think we've all read about the impact of alcohol on the body and the brain. This is kind of a cataloging of it by body system. It's just pervasive. It affects a lot of different things. Some people have talked about health benefits of moderate drinking. And there's debate back and forth about that. There have been different studies, and there's some disagreement, about it. But the consensus is that overall, probably, there are a lot of negatives if you drink to excess. Factors that contribute to binge drinking, family background, which could be genetics or nature or nurture, and then easy availability of alcohol, increases the rate of binge drinking. If it's easy to obtain and it's part of the social culture of your area, people are going to do more of it. There's been a lot of research in alcohol running in families, and it's very hard to tease out whether it's a genetic thing or a cultural thing, but really the effect is, it has effects, so you deal with the effect. There's a high impact of having a family member with alcohol problems. And there's pretty easy access to alcohol, even with underage drinkers. And later I'll have a slide with some Edina data that will point that out. Co-occurring disorders or mental health issues that happen with binge drinking and alcohol abuse are very common. Often people use alcohol to self-medicate. They don't want to go get treatment for a mental health issue to admit they have one, so they will, if they're depressed or whatever, they'll drink instead. And basically, if you look at that population, only 7% of it is being treated for both conditions, and 56% or a majority are not receiving any treatment at all. So that's a tough population to deal with. The outcomes are not as good to begin with, but that's an important consideration. That's very real. There's some good information. I think a lot of this just makes common sense about why people are motivated to drink, teens and adults. Curiosity, social acceptance, just having fun with your friends, feeling more confident, forgetting, like I need a drink, I gotta forget my problems. Being strong or macho, which, often when people drink, they fight, so it creates a mindset. And then asserting your independence, which you like to find ways to do with their parents, so it's, the parents tell you not to, well, then maybe they want to. So those things all come into play, and some of those are kind of positive reasons. We all want to have fun, we all want to be socially accepted, we all want to feel confident, so it's kind of natural that people will be attracted to that. So when does it start? It often starts quite early. 25% of Americans over the age of 18 binge drink, and 7% engaged in binge drinking the last month. So that's kind of where you end up. But if you look at the age group 12 to 20, 5.4 million or 14% binge drink, and that's starting at age 12. So the 12-year-olds are pulling that average down a little bit, with the males tending to do more of it than the females. Youth binge drinking has declined over the past decade, but the problem is still very serious for people age 18 to 22, as we read in the newspaper, because there's a drinking culture on college campuses, and we'll get into that later. If you drink under the age of 18, it can affect your brain structure and how it works in the future. That's very concerning for a community like Edina, where we want our kids to achieve as much as possible. 1 of 4 college students meet the criteria for alcohol use disorder, and if you have that, it's going to have academic consequences. You may not finish school, you may not go to class, it could be a variety of things. And you may have more trouble with relationships and all the things that kind of move you in a positive direction. And it causes significant health effects. Almost 700,000 annual reported assaults, 97,000 sexual assaults reported, and then almost 2,000 deaths. So it's, you know, it has, drinking has an effect. And we're not talking about people having one drink and, you know, with a meal. We're talking about more drinking than that. And it continues into adulthood. 92% of adults who drink excessively report binge drinking in the last 30 days. So again, it's something they're doing currently. Whoops, I'm ahead of myself. Most alcohol consumed by U.S. adults is consumed as part of a binge drink. And this continues past the college age group because 70% of binge drinking episodes are for people over the age 26 and over. And when people binge drink, it's not like once a month, but it averages 4 times a month, consuming 8 drinks per binge, which would bring you up to between 0.50 and 0.20 for most people. And even with the seniors, while they do it less than other adults, when they do it, they're doing an average of 5 to 6 times a month. And because many are retired and kind of socially isolated, they're able to do it without people necessarily knowing that they're doing it. 88 million people annually die from alcohol-related causes. The cost of it is over $220 billion. And if you cost that out per drink, it's like $2 a drink, and it's $750 per person. So this is a fairly significant expense, as well as being a health issue. And we all know the social impact of binge drinking. 10% of kids report, having a parent that has a problem with alcohol. And 65% of U.S. inmates have an alcohol or substance abuse problem. So it explains a lot of what's going on in our criminal justice system. Binge drinking in Minnesota. Among our youth, 9% in the age group 12 to 17 started in the last year, which means that's a 6-year period, so if you multiply 9 times 6, you get up above 50%. The amount that admit binge drinking in a somewhat larger age group is 16%. The most concerning thing in the whole study was 66% of Minnesotans in that age group felt that binge drinking was no real great risk. So they have an attitude about it. So as we see the amount of binge drinking being reduced, we have people that think it's not harmful, and they're probably not doing it because their parents don't want them to, but when they get to college, then that attitude kicks in. And then our treatments, let's see, adults, I have some more data on them, but in both, in the categories that are reported, Minnesota is above the national average. Treatment center census, that's basically any day if you looked at all Minnesota treatment facilities. Back in 2009, there were 14,000 patients. In 2013, there were 18,000 patients, a pretty significant increase. And if you know the business has been shifting away from inpatient, outpatient, and shorter stays and that sort of thing. But that seems like a lot of people in treatment, particularly if you realize that this is one day, and you multiply that times a certain number to get you your annual number. But, and most of those patients actually have the co-occurring diagnosis of, it'd actually be a dual disorder of alcohol plus drug problems. So you're talking about tough, patients are a little bit tougher to treat. But if you look at the state as a whole, only 6% of people that have a problem are getting into treatment each year. So it's like this is kind of the tip of the iceberg. Most people are not receiving services. And then, Edina School Survey. First interesting thing, I don't think that's been reported before, is that when students were asked, 11% of them said that there was drinking, problematic drinking in their household, which is consistent with that national number. So if we want to maintain that we're better somehow than other communities, that does not support that. We're not a lot worse, but we're not better. Sources of alcohol is very interesting. I think we think, oh, they get it, maybe they go to the store or something. That's not how they do it. 12% in both the younger and the older age group said that they had obtained it from any retail outlet, either by stealing it or buying it, and that would be restaurants and all other places where alcohol is served. In fact, they're getting it from other people. And often, you'll see that parents and other family members are included on the list. So think about it, if you have parents that have alcohol problems and you have people that are getting alcohol from their parents, there might be association. The data don't really let us look at that because we don't have crosstabs. I'm sorry, it's skipping ahead on me. I must have a loose trigger finger here. But it's friends, parties, took it from home, kind of the security of the alcohol in the home. So if we think that we're going to take care of the job by clamping down in retail, that's just not going to work. Any alcohol use in the last year, it basically goes up over the years from 16% in 8th grade to almost 50% in 11th grade. And any drinking in the last 30 days, again, you see the same pattern. Binge drinking, not that common with 8th graders, quite a bit more common once they get to 11th grade. And as with most of the data, boys have a bit more of a problem with it than girls, both in terms of how often they drink and how much they drink when they do. So what are the barriers to getting treatment? It's kind of a long list. Denial, kind of peer pressure and lack of support, fear, treatment's difficult, privacy concerns, people can lose their job if they go into treatment, time conflict, it's time, it demands time to get into recovery. The program may cost too much or may be hard to get to. And even when you've decided you want to get in, the program may not have space. So when you have the desire to get in, that's the best time to get in. If you have to wait, then by the time you can get in, you may have lost the desire. And then finally, relapse. No medical care or health care is perfect. And probably 50 to 60% of people that go into a good treatment program will get into recovery, but that leaves the other 40% that don't. So it's certainly not a sure thing, but that's really true of anything that you do in healthcare. How to cut cost, cut the drinking and its cost. There's a community prevention services task force that Matt found the work they're doing, and they've listed some factors here. I think several of which Edina is already doing. And there certainly, we've talked about, the initiatives that are being taken in Edina regarding trying to reduce consumption. And the rates have gone down. I think the one question is, we hold the fort when they're in high school, but then when they hit college and immediately have the problem because they don't think it's harmful, then we've just delayed the problem, we haven't avoided it. So our conclusions are that binge drinking is fairly widespread, that there are social pressures and economic pressures that make it possible. I mean, when more than half of alcohol is sold to binge drinkers, that's a lot of money on the table. You can understand why people aren't going to want to change that. our high education levels may put us at greater risk, although our local data at this point really is not great enough to really conclusively get at that question. Youth drinking in Edina is down, but as long as we have youth that don't think if they do it's a serious problem, we still have a problem. And in terms of how we've approached things, we used to look the other way. Now I think we're trying to do harm reduction, try to reduce the consequences. And the next step is to try to lower, the incidence down to the point, like we've seen with tobacco, that it just is not a cultural norm to want to do it. And again, since 90% of our students go on to college, what happens there is certainly something parents should have an interest in dealing with. In terms of immediate recommendations, and I think essentially Matt developed this list, and it's a good list. We've talked about a chemical health coordinator position, which is on our work plan. And the point he's made, and I would agree totally with, is that if it becomes more of a general position, but the person doesn't have the skill set with addiction issues, then they're not going to be much of a resource for the problem. Am I stating your belief correctly, Matt?
Yes.
Okay, good.
Yeah, we're good.
When you write, you don't always know if you capture it. Supporting local police efforts, which have focused on the youth issue, but also to look at whether there are any enforcement gaps with adults. And I don't know that we necessarily know one way or the other, but it certainly, there are adults in the community that are contributing to the youth problem, so for that reason alone, we should look at it. Look at these community prevention services task force recommendations, and then basically decide if they make sense for the community. And then make sure that the people that do information referral in the community have good information on binge drinking and addiction, and also know how to get people referrals if they need them. And then finally, things that we talked about continuing to work on over the next few months, continuing to advocate for city resources if necessary in the area of this chemical health coordinator position. It may be that if the city wants more of an emphasis on addiction, it's going to have to put some money in to have some influence. Look at our city ordinances. An example would be the city was recently looked at the rule regarding alcohol versus food sales in our local establishments. Well, that's an issue that has implications for binge drinking. Ideas of like brew pubs, alcohol related. So there are things that are going on currently that we need to look at. And then look for areas where we could improve our resources for people to make a more compelling argument, particularly to convince our teens that binge drinking is a serious issue. Some of them understand that now, others don't. Seek out more data and information about Edina and Minnesota so we can make the case that we understand our local problems. And finally, share what we've learned with the City Council and any other groups that they might want to have us share the information with. So that's the end of my presentation. Questions or comments? If you have any edits, like typos or whatever, you can tell me later. We won't get into that level, but.
I was just going to make a quick comment, kind of summarizing some of what we said or talked about. And I mean, the fact is that relatively speaking, a majority consume alcohol with moderation, right? And there's evidence that moderate drinking may be beneficial to one's health. And we weighed all this stuff, and I just want to point that out. And there's evidence that binge drinking has seen some decline. And, taking into consideration whatever our local government's role is supposed to be in this, you have to kind of factor that in as well. I think still, even in view of that, given the fact that there is such a disproportionate impact that's created by those that binge drink or consume alcohol to those excesses, both on them and others in the community, and the potential problems it could generate in the community and continue to generate and carry on through for people's, as they leave our community and potentially come back, that it still will require additional resources and focus in the community in view of those negative impacts, even though there may be those positive things that alcohol may have or impact or, have in people's lives. So just wanted to make sure that, kind of that was clear. We
That's my
considered all that
conclusion,
information.
too.
Yeah, right.
Any other questions or comments?
You're looking at me, so I'll make a comment.
Well, it looks like you're about to.
So, I just thank you for your presentation. I think it was well thought out, and it was great to hear. Just acknowledging what I heard you say from slide 16, we have 16% of our 11th graders who are acknowledging binge drinking in the past 30 days. So that 16% is substantial, and that's concerning. Also would want to recognize then that means 84% are not. And so that's a great thing, and we clearly want to move that dial. But as you were stating, even the small, the 16%, while it's not the majority, that's still a substantial number that is concerning. So I could certainly support the recommendations as far as our involvement in really partnering with the schools and recommending the chemical health coordinator position, and how can we support that education and partnering with not only the schools but the parents and the community and in our actions. So
The comment about that is that the 16%, the 84% are what are reflected in the survey.
Right.
And one can imagine a few students who aren't drinking claiming they're drinking for some reason, but I think it's more likely to go the other way in terms of underreporting.
yeah,
Because with survey data, people are, there's stigma and shame and not wanting to admit you have problems. So, and we find with alcohol, a lot of people don't recognize that they have problems or kind of ignoring it. So it's not like half, but it could be 20%. I mean, but the exact percent is less important than that it's part of the teen culture, and like smoking once was. And it's possible with public health efforts to lower those numbers, and we've seen it in several other areas. So this one's a good candidate too, I think.
Any other comments or questions? I would second Melinda's comment about thanking you for the presentation. I think this was a great compliment to the presentation that the youth themselves gave at our last televised meeting in December, where they were telling us kind of the stories of the high school. This was great to see the data to kind of match the stories that we were hearing. I think we're fortunate in our state to have the Minnesota Student Survey. I know it's a challenge for school districts to implement it, just to offer one more survey in the spring, but I think it's important for organizations like the city and the school districts to have access to that data. I think the fact that this year they asked 8th and 11th graders as the first time they've ever asked those means we lost the ability to trend the data in the past. But I think going forward, we'll have more trend data and be able to watch to see how the numbers are moving.
We can see the slope of what's going on. Our 12th graders have lower levels than 11th graders. That's not plausible.
Yep.
It might not be much higher, but it's at least, I think we can be confident thinking it's at
Yep.
least as high. Because some of them cross the 18 threshold when I think youth tend to think they have a right.
Yeah.
Thank you.
Thank you. Any other questions or comments? Great. We will move on to correspondence. Carla, do you know, did Jeff receive any correspondence at all this month? Okay. And now our chair and commission member comments. Does anyone have any updates or comments?
I just have one comment related to the Edina Highlands Elementary School had a health fair kind of day for some of their classes where individuals came in and spoke on various health topics for a segment of the student population. Member Connor and I actually were able to participate as teachers, faculty for that, and it was a lot of fun. But it's just a reminder, there's also that the Health and Wellness Committee at Edina Highlands that's underway, and so, at the local school, level, we're seeing some activity, which is a good thing.
Any other comments? Joel?
I have one. Last night I read a new draft of a plan, a first draft plan for the Parks and Rec Department, and it was good to see that in their strategies, they had a lot of things devoted to health. One thing was to increase the number of miles of walking trails in the community significantly and try to, I guess, connect trails together better. And the Transportation Committee has also been, had a significant interest in improving sidewalks and crosswalks. And so there are other commissions that are doing things that support our efforts. Good to be aware of that. And I don't know if you talk to people from those commissions, thank them probably.
Any other comments? I just had a couple, thank you for the park strategic plan. They're actually, I believe that's being presented to the city council on Wednesday as part of their work session. So we can keep an eye on that. I believe that's going to move forward in June. And then the Living Streets Plan, which was came out of the Transportation Commission, has its public hearing on Wednesday during the city council meeting as well. So people can look up the details on the Living Streets Plan. You can also make a comment on Speak Up Edina if anyone has comments, or you're welcome to come here and testify during the public hearing. Did you have a comment?
I thought of something else. The Grandview project is moving along, and it appears like they're moving toward more having a bigger public component, possibly a art center with performing arts space. And there was discussion going back and forth about, well, is it going to be all privately owned space? But it appears that public purposes will be served, and obviously those recreational activities are health enhancing, so another positive development.
There was also a senior health fair in the city, I believe it was last Thursday. Jeff, our staff liaison, attended on behalf of the community health program. I believe it was coordinated by the fire department in coordination with the senior center. So I have not heard how it went, so we could hopefully get an update from Jeff at the next meeting, hear how well it was attended and how it went. And then another update from Jeff Brown was that at our June meeting, which will be right after our work session with the city council, Jeff Jorgensen, who is the director of student support services at the Edina Public Schools, is going to come and present to us about this student wellness coordinator that they're in the process of hiring at the Edina schools. So we had actually hoped he was going to be able to come tonight, but they put it off till next month. They believe they're going to have the position ready. So he's going to come and talk with us about the student wellness coordinator, and we're going to be able to give our input as to our thoughts on making sure that there's enough chemical health included in that position. Any other thoughts or comments? Anything else for the good of the order? Hearing none, I'll take a motion to adjourn.
So moved.
Second.
All in favor?
Aye.
Okay. Meeting adjourned. Thank you.